Well, first and foremost, thank you for having me here. It's actually an honor to look outside the audience and realize it's almost 4 o'clock and everybody is still here. Despite lunch, postprandial, sleepiness, everybody's here. That's amazing. Even when you go to a physician conference, you never see this kind of attendance. So actually, I was going to say, and now for something different, unfortunately, I can't say that. We have a lot of overlap. So my job is to talk about somatostatin analog in neuroendocrine tumor. What I'll try to do is try not to spend a lot of time on what is already been said, but try to give you a little spin about my interpretation of the data out there, if I could. So just a little bit more about somatostatin receptors. These are highly expressed in gastrinoma, in selenomas, midgut neuroendocrine tumor, and metastatic and metastasis of neuroendocrine tumor. Undifferentiated or poorly differentiated neuroendocrine tumor rarely express somatostatin receptors. So you can see here on the diagram that midgut, gastrinoma, insulinoma, and even non-functional pancreatic neuroendocrine tumor has a high expression, particularly in somatostatin receptor 2 and somatostatin receptor 1 as well as 5. But somatostatin receptor 4, it's a little bit less, and 3 as well. What that means is probably variability in the response and side effect. The mechanism of action you've already heard, but for symptomatic control, the reason somatostatin analog work is that it inhibits synthesis and release of bioactive substance, and it enhances fluid absorption in the GI tracts to help diminish secretory diarrhea, which we have spent a lot of time talking about on. So the other reason it works is that it affects these receptor, it generates these mechanism or these pathway by way of interaction through the receptors of somatostatin. As far as anti-tumor activity, it does so, at least proposed mechanism is that it does so by apoptosis or cell death, enhanced cell death and proliferation or inhibition of proliferation. So this is a proposed mechanism. There's no test on this. It's just mainly colorful and hopefully to wake you up. On the left-hand side, or my left-hand side, is the mechanism where anti-tumor effect is usually a result where you can see that there is increase in apoptosis or cell death, and then a decrease in proliferation or anti-proliferative effect. And on the right side is the mechanism whereby hormones is increased in secretions through the cyclase pathway and the pump associated with calcium mediated pump. So you think this is difficult. This is not that difficult. The actual mechanism is actually even more complicated. I think they're all Greek to me most of the time, but there are more and more pathway and more interaction downstream of the somatostatin receptor that are involved to generate either anti-tumor effect or symptomatic control, decreasing in hormonal secretion. Not going to spend a lot of time of this. Human body has naturally has somatostatin. What we have available for treatment is somatostatin analog, Octreotide, and Lanreotide. The receptor affinity for each of these compounds is summarized in this table. You can see that for somatostatin 14 amino acid, it has a specific receptor's affinity versus the other somatostatin 28 receptors versus the synthesis or the analog, Octreotide, Lanreotide. Just to emphasize, most of these somatostatin analogs, both the one that is available in the human as well as those that are available for treatment at the moment, are specific for somatostatin receptor subtype 2 and subtype 5. So that's actually important to know, because as we're developing more somatostatin analogs, manipulation of these receptors is actually probably the key in trying to elicit more response or more symptomatic control. So in my opinion, the way I approach patient who has unresectable or metastatic neuroendocrine tumor that's well differentiated is this. Indication for initiation of therapy, I think progressive disease and or symptomatic disease, meaning to palliate the symptoms or to control the symptoms. And another one, which is actually not the standard of care, but it is something that we do, because many patients, if surgically remove their tumor, both primary and metastatic is feasible. If somehow we can bring them to that level, then they're better off as far as survival, symptoms management, and their disease course may be modified significantly. So that, the other reason is called cytoreduction of borderline resectable disease, meaning reduce the tumor enough so that maybe they can go to surgery to do resection. The other things to remember when you're selecting a agent or deciding to start therapy is goals of systemic therapy. There's only really two goals. One is cancer-related symptoms to control that, and one is cancer progression or tumor progression or disease progression. That is to control all of those. They mean the same thing. For symptomatic control, how are somatostatin analog, how good are they? Well, this slide actually summarizes how good they are. There are multiple studies, all before the year 2000 here, because it's been approved, so most of these are now not being done for symptomatic control anymore. But you can see that majority of them show a pretty good hormonal control, pretty good symptomatic response or symptomatic control with somatostatin analog, both with Lanreotide as well as Octreotide. So I think at some point there's actually a comparison on the O'Toole 1999 study comparing the symptomatic control between Octreotide and Lanreotide, which essentially show no difference between symptomatic control and biochemical response. So perhaps these two are, in a sense, within the same class and behave pretty much the same, if not different for other qualities. So maybe symptoms-wise, they are the same. However, as far as disease control, the two contrasts or the two studies that we're going to bring up is one that has already been brought up 3 or 4 times today or this afternoon, is the PROMID study, which assessed Octreotide versus placebo, and the CLARINET, which assessed Lanreotide versus placebo. This is the study design of PROMID, essentially taking patients who are treatment naive, well-differentiated neuroendocrine tumor of the midgut, randomize them to Octreotide LAR 30 milligram every 28 days versus placebo, and they get treatment until progression of disease. The primary endpoint here is time to tumor progression, and the secondary endpoints are listed here, objective response rate and quality of life and such. The take-home message of the PROMID study is this: the two curves that you have are the two curves of the two arms. They separate from the very beginning. So that means there are benefit with Octreotide LAR. The improvement is going from 6 months to 14 months in time to tumor progression. And this is statistically significant, but more importantly, it is clinically significant. So the summary of the PROMID study is that the Octreotide LAR slowed time to tumor progression in patients with advanced midgut, G1 particularly, going from 6 months to 14 months. The benefit seen here is regardless of functionality of disease, because patients on here were allowed to be either functional or non-functional, meaning having symptoms as a result of hormone oversecretion or not. Hepatic tumor load, however, is a favorable predictor of the benefit with Octreotide LAR in this particular study. A tumor load in the liver that is less than 10% seems to be statistically significant in predicting better improvement in time to tumor progression. So the study seems to say that patient who has lower burden of disease in the liver may benefit more than those that have higher. But 10% to me is a very low cutoff of what is in the tumor in the liver. So put that in your mind. We're moving on to the CLARINET study. CLARINET study is Lanreotide versus placebo. It is also another randomized study. It took patient that has well-differentiated neuroendocrine tumor of the gastrointestinal pancreatic tract that is well-differentiated, consistent of both grade 1 and 2. And they actually, what they did, what Emily has said, is that they took patients, they enrolled them, but they don't start therapy until they have another scan in a period between 12 to 24 months. If they essentially trying to see if they have progression of disease. We're trying to establish baseline in this study. Then they get randomized 1:1 to 2 arms, Lanreotide plus placebo, and then the treatment to time to treat to progression of disease or death. It's actually very interesting on how you use these patients and give them placebo control and how you control. It's blinded placebo control. That means the investigator, the patient, are not aware of what therapy was given to them. And the only way to do this is if they're back behind, if you're giving the therapy behind their back and by a nurse that is not part of the clinic. In any case, it's amazing. The study was finished, and the primary endpoint here is that progression-free survival at 96 weeks, and secondary endpoint are listed there: time to tumor progression, overall survival, pomegranate A response, safety, quality of life, and PK. Again, the curves here, the take-home message of the study, the two curves separate from the very beginning, showing a 40% absolute reduction in progression-free survival an improvement, a 40% improvement in progression-free survival with Lanreotide compared to placebo in these patients with advanced GEP-NET or gastrointestinal pancreatic neuroendocrine tumor. The summary here, this is essentially show that Lanreotide improved progression-free survival. You all know that by this time, but it is in patient that has advanced gastrointestinal entero, essentially, pancreatic neuroendocrine tumor, grade 1 and 2, and they differ between 18 months versus 26 months. Actually, it's not reached at 26 months, so potentially it's actually a lot longer. It is a 53% relative risk reduction in progression-free, for progression or death, and an absolute improvement, as I said, is 40%. The improvement here of PFS is in both G1 and G2, midgut, and pancreatic neuroendocrine tumor, and regardless of hepatic load. So I think the best way to analyze or to look at the two studies to see what relevant here. Obviously, the study are very different. The study are meant not to compare, but if you look at some characteristic of the study, you can actually try to get some interpretation or some extrapolation of what group of patient perhaps can benefit from Lanreotide versus Octreotide versus Somatostatin Analog in general. The two study, as far as the study design is concerned, the PROMID study was planned for 162 patients, but it was analyzed at 85. And the CLARINET was planned at 204 or above 200, and they actually complete their accrual. So one study is smaller or analyzed at a smaller number than the other one. The other is actually the primary site. PROMID was predominantly midgut, where 75% were confirmed midgut, small bowel neuroendocrine tumor, and about 25% are unknown, which clinically is supposed to be neuroendocrine tumor of the midgut, whereas the CLARINET consists of patient that has gastroenteropancreatic neuroendocrine tumor, which means midgut, hindgut, and pancreatic well-differentiated neuroendocrine tumor. The other thing that is different between the two studies is that the PROMID is treatment naive, meaning patient who has no prior therapy, whereas CLARINET allow for prior therapy, but they have to have enough washout period before they get on the study, at least 6 months. The functionality of the study, of the baseline of the patient that got enrolled, for the PROMID, they allow both symptomatic and asymptomatic, but for the CLARINET, it's all asymptomatic, non-functioning neuroendocrine tumor. Grade 1 is in PROMID, and grade 1 and 2 in CLARINET. In fact, Emily, there are actually more than 30% of patients that has grade 2 in the CLARINET study, so it's not a small number. The primary endpoint for both are relatively the same, but they measure a little bit differently. One is measured by WHO criteria, and the other one is by RECIST criteria, and I don't know if you can see all the way down, but progression of disease at the baseline is unknown in the PROMID study, and in the CLARINET, it's 96% were stable disease at baseline. So what it means is that we have no idea in the PROMID study where the starting point is. Are they progressing, or are they at stable disease? Whereas in the CLARINET, 96% are stable disease, which also, exactly as Emily said, is that they may be suggestive of indolent disease more than it is rapidly progressing disease, like in the other study that's been done. The other thing to compare is put side by side the outcomes. So again, one is a larger study, one is not. PROMID 85, CLARINET was analyzed at 204. The primary sites of disease in midgut for the PROMID, there's actually 64 patients that has midgut. None has pancreatic neuroendocrine tumor. Almost as much of the study for PROMID with midgut disease was seen in the CLARINET, where there's 73 patients with midgut neuroendocrine tumor and 91 patients, or 45% of the population in CLARINET had pancreatic neuroendocrine tumor. It's actually a large number. If you're able to make interpretation from 85, if the study was designed preliminary just to analyze these group and not necessarily a subgroup, then you probably can make some interpretation. The progression of disease as far as baseline is concerned, one is unknown, and we talked about it. 96% has progressive at stable disease, which means 4% has progression of disease. The other thing that is of interest when I was putting this slide together is this. The time since diagnosis for patient on PROMID is 3 months to 7.5 months between placebo and the Octreotide arm, whereas the other is 16.5 months and 13.2 months. This clearly says that it's consistent with people who had previous treatment on the CLARINET study, whereas PROMID is treatment naive. There's a difference in natural history of disease as far as who is enrolled in which study. The other things to note is that the primary outcome as far as time to tumor progression or progression-free survival, I've just put them together. They're a little bit defined differently, and as a result, the data is different. The primary outcome for midgut in placebo is 6 months, with Octreotide is 14 months, whereas in the CLARINET for midgut is 21 months, going to beyond 27 months, meaning that at 27 months, the progression-free survival is not reached. For pancreatic neuroendocrine tumor, that was not analyzed in the PROMID, or that was not studied in PROMID, but in CLARINET, the placebo arm has 12 months, and then the treatment arm with Lanreotide was not reached at the 27 months, which means that the progression-free survival is likely beyond 27 months. The other thing that is very interesting to me, and I actually keep looking at this over and over again to see if I missed something, chromogranin A response rate was not significant in the PROMID study with Octreotide, but chromogranin A was difference between those that got placebo versus those that got Lanreotide. Now, whether that is because you have a more robust group of patients to analyze for chromogranin A response, I can't answer that because there's not enough, it's subgroup upon subgroup. But it is actually interesting that historically, you know that both of these drugs should have relatively similar ability in controlling symptoms as well as biochemical production. But in in subgroup analysis, it's not demonstrated. Quality of life was not changed significantly whether you treat with Octreotide or Lanreotide. Perhaps what it's mean is majority of patient has good overall quality of life, and being on these drugs, whether it's Octreotide or Lanreotide, does not decrease their quality of life, because it's very difficult to see if you can improve quality of life if you're already relatively normal. So Octreotide versus Lanreotide, what does these mean, these two studies? The only thing that you can say here, or at least the only thing I can say, is that the result of both confirm that there is an anti-proliferative effect of somatostatin analog in well-differentiated neuroendocrine tumor. CLARINET study was assessed in a very different subgroup of patients. They are previously treated. Disease status at baseline are predominantly stable disease. They include pancreas, midgut, and hindgut, and they include G1 and G2. And the analysis of effectiveness based on hepatic tumor load is actually breakdown at 25% involvement versus greater than 25% involvement. The PROMID study mainly treat patient was therapy naive without disease known status, meaning at baseline. Have they been progressing on no therapy, or it's not clear. It's only midgut that has been included in the PROMID study, G1 mostly, and hepatic burden was only significant if you have less than 10%, meaning the benefit was seen with patient less than 10% involved in the liver. So shifting gear for a little bit, I'm just going to talk about the other somatostatin analog, which is Pasreotide. And you can see here, actually, the affinity of Pasreotide is actually for somatostatin subtype 5. The other one exists as well. They're all for 1, 2, 3, and 5, except 4. It doesn't have a lot of affinity for 4, but the most affinity that Pasreotide had is with somatostatin receptor subtype 5. That this is showing essentially in human somatostatin, it has an effect on all of those subtypes. Lanreotide, Octreotide, predominantly somatostatin receptor 2, Pasreotide, predominantly somatostatin receptor subtype 5. So the study that Dr. Woolen has mentioned is I think it's a phase 3, but on his slides, phase 2, but it is a randomized study for patient that has refractory to prior somatostatin analog. Accrual N early because of futility. They accrue 110 patients. The primary endpoint here is not progression-free survival, but symptoms respond. The outcomes is shown that symptoms respond was essentially not different at 6 months between Pasreotide, 21%, and versus Octreotide, 27%, not statistically significant. However, progression-free survival at 5 months seems to be a little bit better with, I'm sorry, I mixed those up, with Pasreotide. The grade 3 and 4 adverse effect actually seems to be more with Pasreotide, mainly in hyperglycemia. There are ongoing studies with Pasreotide. We hope to hear about the Cooperate 1 study result in ESMO. It's where patients are treated with Pasreotide in combination with Afinitor or everolimus in advanced metastatic pancreatic neuroendocrine tumor. So shifting gear and talking about another target of somatostatin receptor is the peptide receptor radiolabel. This is a systemic radiotherapy targeting somatostatin receptor. The compounds, which one to use, varies by the isotope that's used, whether it's indium, yttrium, or the other lutetium, and it varies by the carrier molecule attached to the isotope. They can be dotatate, different carrier is used. They're listed here are 3. So lutetium dotatate and yttrium dotatalk had promising result in phase 2 study. Let me just show you the phase 2 study in the lutetium dotatate phase 2 study. Actually, this is a single arm study. Essentially, I believe it's retrospective evaluation or prospective, but it is an open label single arm study. Patient was treated with lutetium dotatate, and 504 patients was treated. The efficacy evaluation was done in 310 patients, not intended to treat. The study report a response rate of 30%, which is excellent, with a median time to tumor progression of 40 months and median overall survival of 46 months, which is stellar. However, the problem here is that the study was analyzed in only 310 patients. What it should be analyzed in is 504. If you do analyze the response in 504, the response rate dropped down to 18%. Higher report time to tumor progression was only calculated again for 249 patients who did not have progression of disease as best treatment outcome. Clearly, this is a single-arm study requiring randomized prospective study to assess the role of PRRT, and that's what's going. NETTER-1 is the one that's ongoing now with lutetium dotatate against Octreotide LAR in midgut neuroendocrine tumor. And other studies are listed here. CASTOR is not open yet, but I was looking on clinicaltrial.gov. It is actually a PRRT versus interferon in carcinoid after failure to somatostatin analog. I suspect it's in Europe because it's very hard to get my patient here in US to take interferon. So it is not yet open. So the conclusion here about somatostatin analog is this. Somatostatin analog are effective and useful for symptomatic and biochemical control and to improve essentially symptoms control. It is effective as an anti-proliferative agent to control disease and mainly to stabilize disease or cytostatic. CLARINET treat patient with advanced neuroendocrine tumor that is of well differentiated, but they extend the applicability to midgut as well as pancreas, as well as grade 2 and 1, as well as those that has hepatic tumor load that is greater than 25%. The future challenges for somatostatin analog is the timing of somatostatin analog. As you can see in both these studies, majority of the patients are either very early on, no therapy before, or very indolent disease in later course of their natural history of disease and haven't progressed. And then the other challenges is combination therapy. When you combine somatostatin analog, now that you know it has an anti-tumor effect, when you add it with other agent, is it synergistic? Is it additive? How do you account for that when you calculate response for the other agent that's being analyzed? And then the biomarkers. We need to have biomarkers. That's the way for the future to predict response for somatostatin analog. As any targeted therapy, and this is a target therapy, we need to figure a way to predict which patient would benefit from somatostatin analog and which won't. And that's something that I encourage the sponsor, the pharmaceutical company, to look for that, and of course, investigator. That ends my talk. Thank you very much.
Thank you very much, Dr. Feng. That was excellent.